Welcome to our 10th lesson. In this lesson we talk about loss, grief and bereavement. Please be aware that discussing loss and grief may affect your emotions and personal grief process if you have experienced significant losses at any time in your life. It is very important to notice your reactions and possibly seek help if needed. This session concentrates on loss, grief and bereavement. We will take a look at the definitions, healthcare relevant management strategies, and inspect helpful and unhelpful coping strategies. Identify and describe the losses, and their impact, that patients and their families face across the illness trajectory and, for families, after death. Describe and differentiate between loss, grief, bereavement and mourning, including triggers for abnormal or prolonged grief reactions. Describe normal grief patterns. Identify common loss and grief models and describe their value for practice, including identification of complex grief. And give guidelines and tips for first intervention, after the loss. First of all, some general facts about loss, grief and bereavement. Why loss, grief and bereavement concern us all. Health and well-being are of importance to everyone. A diagnosis of Parkinson's disease has a significant impact on both the person diagnosed and their loved ones. Necessary supports for loss and grief are individual and requires understanding and active engagement with patients and families. According to Gofton et al., facing palliative neurology practice comes with three main challenges. Firstly, uncertainty with respect to prognosis, support availability and disease trajectory. Secondly, inconsistency in information, attitudes and skills among care providers, care teams, caregivers and families. Thirdly, existential distress specific to neurological disease, including emotional, psychological and spiritual distress resulting from loss of function, autonomy and death. Patients diagnosed with Parkinson's disease suffer from loss and grief caused by loss of autonomy, function and meaning. Caring for someone with a long-term progressing illness may cause feeling of loss and anticipatory grief, both experienced before a bereavement. Also, healthcare professionals may suffer from loss and grief in providing care for patients and their caregivers with life-limiting chronic conditions. For this reason, focusing on loss, grief and bereavement should be timely and continuous. Patients and caregivers should be advised to monitor their feelings of loss and grief, and provided with emotional, psychological and spiritual support and counseling, where and when needed. Furthermore, self-care strategies for healthcare professionals have to be considered and at place. To prevent burnout and suffering from mental and physical ill health. Like in other chronic conditions, loss, grief, and bereavement is commonly experienced by those diagnosed with Parkinson's disease, caring for a family member with Parkinson's disease, and it is also common in healthcare professionals, who equally belong to the unit of care. Dealing with loss, grief and bereavement for the person themselves, their family and the professionals who care for them is intrinsic to palliative care provision. Most people manage loss by combining their own resources with support from family and friends. However, a minority of people are at risk of developing complications or difficulties in their grieving. Healthcare professionals have an important role to play in supporting bereaved people by providing information and support to all and by identifying those who require bereavement therapy or counseling. As healthcare professional, you should understand that grief is a normal and appropriate response to loss which has physical, psychological, spiritual, emotional and social aspects that affect how it is experienced. Recognize the range of individual physical, psychological, spiritual, emotional and social responses to loss and grief. Recognize the factors which may put a person at risk of encountering difficulties in their grief, whilst also remaining aware of the resources and resiliencies that are particular to each person and family. Demonstrate an ability to engage with a person who is experiencing loss in the context of professional scope of practice and/or role. Assist the family to access bereavement information and support at a level that is appropriate to their needs. Furthermore, you should understand the personal impact of loss, grief and bereavement, and recognize your own loss responses and engage in activities that maintain your resilience on an ongoing basis. Possess a level of self-awareness that prevents your own experiences of loss from negatively impacting on the person with a life-limiting condition or their family. Demonstrate understanding of normal and pathological responses to the diagnosis or prognosis of a life-limiting condition, and an ability to address the immediate management of such responses. Work in partnership with parents, guardians and other family members in order to prepare and support children and vulnerable adults for the loss of loved ones. Facilitate the person with a life-limiting condition and their carers to express their thoughts and feelings relating to illness and loss. At this point we have used the words loss, grief, bereavement and mourning. Hence, you might want to ask yourself, what do the terms loss, tangible or intangible, grief, bereavement, mourning mean to you? Let us take a look at available definitions. Loss refers to a situation when you no longer have something because you don't know where it is, or it has been taken away from you. Grief is an emotional and psychological reaction to loss. Grieving refers to the psychological components of bereavement, the feelings evoked by a significant loss, especially the suffering entailed when a loved one dies. The actions and manner of expressing grief are culturally related. Bereavement is a progression through the stages of grief prior to the loss. Bereavement comes with a feeling of to be robbed or deprived of something valuable. In our society it commonly refers to the death of a significant person. Mourning refers to social expressions or acts expressive of grief that are shaped by a given society or social group. Bereavement can be expressed in various acts of mourning such as funeral ceremonies or the withdrawing from public activities. Grieving and mourning have been conceived as the processes whereby the bereaved person adjusts to the reality of their loss, enabling them to disengage from the deceased and reinvest in new relationships and living situations. There are different types of loss, such as tangible, actual or physical, losses, which are apparent and easily recognized, such as loss of a body part, changes in physical health, loss of personal belongings. And then there are intangible losses or perceived or psychological losses, which are less obvious, such as loss of prestige, power, security, loss of hopes and dreams for self and others, loss of faith in own belief system. It is important to remember that each person has an individual response to their specific loss. Theoretical concepts of what is normal regarding bereavement can help predict a greater risk of complicated bereavement, and even diagnosis of pathological, unresolved grief. People who have been confronted with Parkinson's disease confirm the feelings of loss, however, they also express that besides having Parkinson's there is still a life to life and choices to make. In one interview Ozzy Osbourne has uttered, "Of all the things I've lost, I miss my mind the most." And Michael J. Fox has added, "I don't have any choice whether or not I have Parkinson's, but surrounding that non-choice is a million other choices that I can make." Terry Pratchett announced his diagnosis with early-onset Alzheimer's disease, calling it an embuggerance, when he pulled out of a planned summer Discworld festival. Shortly before his death, he told the embuggerance is finally catching up with me. We go on to the relevance of loss, grief management and bereavement support. In Parkinson's and related disease, the illness trajectory is difficult to predict. Due to the limited access to neurology specialists, it can take a long time until patients receive a diagnosis. Many patients with Parkinson's disease react well to medication. This phase is also known as the honeymoon phase. Strong hopes can be connected to feeling better or with promises of finding the cure for Parkinson's. Still, Parkinson's disease is a progressive disease that comes with disability and frailty. Thus, the illness trajectory can be seen as a cycle that contains promises, hopes and losses. The loss cycle in the diagnosis of a chronic life-limiting condition begins with progressive symptoms that lead to specialist referrals and clinical investigation. The diagnosis, treatment, and nurture hope, but also cause the feeling of loss. When symptoms, disability and frailty progress and treatments fail, the loss experience is to be seen as a cycle, which needs careful monitoring. The diagnosis of neurodegenerative disease is devastating for patients and their families and comes with many uncertainties. It challenges the patients emotionally, compromises identity, challenges independence, forces patients and their caregivers into social isolation, and threatens the ability to find meaning and purpose in life. The bodily failure and Parkinson's-specific symptoms such as tremor, drooling, incontinence, may make patients to withdraw themselves from friends and family and social activities. Accordingly, the most difficult challenge for people with neurodegenerative diseases is maintaining a sense of self in the context of a neurological condition. Accordingly, Penner and Roger suggest care must attend to the deep needs of these individuals by communicating in a style that addresses both emotional and cognitive needs of patients, by thorough and holistic assessment, and by appropriate referrals. Since many people are unaware of the physical demonstrations of Parkinson's disease, stigma may arise due to visible symptoms experienced by people living with Parkinson's disease. Shakiness, the inability to talk or to stand still, as well as cognitive decline, lead to negative misconceptions in public environments. Some patients share instances of being characterized as lazy or looking a little slow. A few described being mistakenly perceived as drunk due to the uncontrollable motor symptoms or the inability to complete tasks. Stigma may also be a result of relational and communication problems. In addition to being misperceived due to physical behaviors such as tremors, facial muscle rigidity makes it difficult for people living with Parkinson's disease to express themselves and convey their beliefs. This causes progressive frustration, especially with family members or caregivers who have replaced them in discussion or decision-making. Consequently, it is common for patients to complain about not receiving the right time to express themselves and therefore not receiving the adequate help or treatment. Nonetheless, stigma is not only linked to observable characteristics of patients with Parkinson's disease but also to the loss of functionality. Stigma may also be self-attributed when patients develop a physical dependency and lose autonomy. Another reason for social stigmatization is due to the common belief that Parkinson's is a disease only for old people. This prejudice is strong in society, including family members. Altogether, stigma results in patients feeling ashamed and embarrassed, which often leads to isolation and therefore declined quality of health. Thus, it is crucial that patients are in contact with their friends and family so that their physical and social needs are met. By doing so, it may guide healthcare professionals and caregivers to a more fitted and tailored manner of treating the patient. The patient and caregiver-centered care is of particular importance as the family members feel equally sad due to the diagnosis. They experience fear, because of the uncertainty of the future, lack of knowledge and difficulty of accepting the disease. The physical presence but psychological or emotional absence leads to the feeling that the person is absent, and the relationship is lost. The ways to deal with change and loss are to retain hope that things will be manageable. Retain a positive sense of self, to be able to recruit and accept help and depend on others. Feeling of value to others and to the society. These ways of dealing with change and loss must be acknowledged, recognized and supported by professional caregivers. There is no one model that serves all. Some caregivers find comfort in support groups, others are relieved if they can stick to their normal activities as much as possible. Researchers have developed and modified several models that try to capture the experiences of grief and loss. Maslow's hierarchy of needs will not be new to most of you. Maslow's model acknowledges our human or existential urge to grow, to seek happiness and fulfillment, and to live up to our full potential. As healthcare providers, we tend to focus on low-level basic needs, such as health and safety. In order to deal with change and loss, patients need to be adequately supported to maintain hope that things will be manageable, retain a positive sense of self, accept help and be able to depend on others, feel of value to others or society. There are numerous of grief and bereavement. Whilst most models of loss concern the experiences of carers coping with bereavement, it has been suggested that they are equally explicable to those facing any significant losses, including those caused by advanced, non-curative illness. Principally, models of grief act as guides to enable us and those who are bereaved to make sense of the intense emotions, feelings, thoughts and behaviors which may be experienced during grieving. Elizabeth Kubler-Ross has been widely acknowledged as one of the foremost authorities in the field of death, dying and transition. She recognized grief as a distinct syndrome in dying patients with 5 stages of adjustment to the loss: denial, anger, bargaining, depression and acceptance. In the last book Elizabeth Kubler-Ross co-authored before her death, she states that her stages of grief have been much misunderstood and misrepresented over the years. They are not stops on some linear timeline in grief. Not everyone goes through all of them or goes in a prescribed order. This model also does not adequately address the physical symptoms of loss or spiritual questioning, for example whether this illness is balancing out a previously overly contented life. There are different views and theories regarding loss and grief. However, it is essential that people adapt to their loss by working through the phases, tasks or stages of grief. People cannot handle the emotional impact of a loss until they have come to terms with the fact that the loss has happened. The concept of elaboration or grief work arises from Freudian conceptualizations. Mourning is invariably the reaction to the loss of a loved one, or an abstraction that has taken its place, a homeland for example, or freedom, or an ideal or so on. Well, what is the work of mourning? I do not think I am forcing things if I describe it in the following way: the examination of reality has shown that the beloved object is no longer there and is beginning to demand that all libido be withdrawn from what is connected with that object. However, once the work of mourning is completed, the ego becomes free and uninhibited. The grief work for Freud is therefore that libidinal disinvestment that the ego should do towards the lost person, the object, in order to become available again for new ties. However, according to Philippe Forrest, grief does not involve an elaboration, but a sacrifice. It presupposes that self-abandonment, that voluntary mutilation by which the living person lets the dead person take a part of him into the grave. Grief is a sacrifice, that of renouncing for the things that the relationship guaranteed: protection, safety, nourishment, affection, attachment, pleasure, future, project, and so on. Children may need special attention. According to Kubler-Ross, up to the age of 3 a child is concerned only about separation. Also, death is not a permanent fact for a 3-year-old. It can feel temporary. After age 5, children regard death as meaning someone has been taken away. Around age 9 to 10 the realistic conception begins to show. They begin to understand that death is a permanent biological process. Accordingly, in smaller children the feeling of loss and the anxiety related to loss and grief may be a sudden burst of feelings and unexplained emotions that vanish equally fast, but still need full attention. For children's grief, consult available guidelines in the additional resources section of this lesson. There are many books to talk about loss, death, dying, and grief. Children, like adults, may benefit from attending bereavement groups. Not all grief is pathological, needing professional help, but it is important to notice the difference between normal grief patterns and those that possibly need interventions. In 2003, Warden, a clinical psychologist, introduced the concept that grief and loss required active participation by the mourner in order to achieve adjustment to their new situation. In this model, patients must work through the emotional pain of their loss, whilst adjusting to changes in their circumstances, role, status and identity. His task-based model has been adapted specifically for those faced with a life-threatening illness rather than a bereavement. In this new model, the first phase is pre-diagnostic, when symptoms present and tests are performed. The acute phase then follows when the patient is given their diagnosis, and must face this and decisions regarding potential treatment options. This parallels Warden's first morning task, where the reality of the loss must be faced. The chronic phase is when the patient must cope with ongoing life demands whilst coping with treatment or ongoing effects of the illness, working through Warden's second task of pain and grief. The final phase in the case of a non-curative illness is the recognition that death is inevitable and that life can no longer be significantly prolonged. Warden himself warns that these feelings and emotions and adaptations do not fit into neat boxes. People will move back and forth from one task to another during their grief. Grief not only elicits emotional disturbances, but also physical symptoms, such as tightness in chest, breathlessness, loss of appetite, or affects our behavior, such as disturbed sleeping patterns, difficulties with remembering, or hyperactivity. The mixture of various sensations and feelings are considered to be a normal component of grief, and it may be helpful if those who are grieving have such symptoms affirmed as normal. It is also important to confirm that grief will never vanish and may return unexpectedly. Rituals related to mourning are to guide people through the most difficult times. However, the secular world does not provide time for such mourning rituals and expects people to return to work, which may complicate the grief and bereavement. In Parkinson's disease, the relationship between caregiver experiences of caregiving burden, depression and grief is likely to be multidirectional. For example, grief and caregiver burden can lead to depressive symptoms, while depression can worsen feelings of grief and burden. According to Fox et al., anticipatory grief was more common among carers of a loved one with Parkinson's disease experiencing hallucinations, repetitive questioning, and agitation. Cognitive decline and other non-motor symptoms are particular risk factors for anticipatory grief in Parkinson's disease. Increasing levels of anticipatory grief may be associated with more limited mobility, difficulties sleeping and in performing activities of daily living. This is in keeping with the multiple losses associated with progressing Parkinson's disease being associated with grief while the person is still alive. Greater anticipatory grief is typically experienced among carers whose loved one was younger and who therefore tended to be younger themselves, and therefore, having experienced less loss and grief. What do the terms anticipatory grief, complex grief, disenfranchised grief mean to you? Anticipatory grief describes the progression through the stages of grief prior to the loss. Complex grief is sometimes also called as complicated grief, traumatic grief, prolonged grief or chronic grief. This extreme grief is characterized by a yearning and longing for a normality which impacts negatively on a person's relationships, employment and life. This condition may need professional assessment and supervision. And finally, disenfranchised grief is a grief form, which is unrecognized by society because of the relationship to the deceased, the perceived importance of the loss or poor understanding of the need to grieve a loss over time, and during significant anniversaries or events. Both the stages and tasks of mourning suggest that acceptance and coming to terms with loss is paramount to avoid complicated grief and greater anguish in the longer term. Continuing Bond's theory, Silverman and Class challenged these earlier models, suggesting that major loss can never fully be reconciled. Instead, the patient as well as the caregivers must live with the knowledge of their loss and incorporate the feelings this invokes into their daily lives. Silverman and Class do not see bereavement or grieving as ever fully resolved, culminating in closure or recovery. They propose that rather than letting go, the bereaved person negotiates and renegotiates the meaning of their loss over time. Death is permanent, however grieving and mourning can maintain the presence of the deceased in the web of the family. They are remembered and not forgotten, they continue to have a role in the memories of the bereaved. The dual process model developed by Struber and Schutt in 1999 looks at grief work as a process whereby the person suffering the loss copes by facing their emotions for part of the time, switching to tasks which allow escape from their emotions when they become overwhelmed by them. Grief only becomes complicated when a patient becomes stuck in persistent grieving without the ability to switch off, or when they are avoiding dealing with the loss completely and continue to live as if nothing happened. There are occasions when exploring the loss and encouraging the patient to move out of denial may be detrimental to quality of life rather than improving it. Sandman suggests that where a patient has no significant unfinished business, has no desire to finish business or make amends, or if the patient is unable to fulfill desires due to incapacity, then becoming aware of their imminent demise will only cause greater anguish. Accepting the diagnosis may only cause the patient to give up rather than seek to resolve unfinished business. The recognition by family of the incurable and advanced nature of the illness may also cause relationship changes that are detrimental to quality of life. In a recent review, Struber et al. From 2005 reported that during uncomplicated grieving there is little evidence of a beneficial effect of divulging and working through emotions when grief work is instigated by a third party. Writing or talking about disturbing or traumatic loss may be most beneficial to those who find it difficult to openly display their emotions, or for those who are presenting with signs of complicated grieving. Do men and women grieve differently? Men are growing up encouraged to be strong, do not show their feelings, do not talk about emotions. Hence, men may need encouragement to talk about loss and permission to express feelings. Women, on the other hand, are to have a good cry, share emotions and feelings. Women may need support to rethink and replan life without the deceased. However, such suggestions must be critically revised. In care situation, address individual coping strategies and methods gained via previous losses and life experiences. Pay attention to potential risk factors related to coping with loss. Practicing in culturally safe ways is estimated to improve access to and quality of care. Healthcare professionals need to remember that culture may also affect how a person expresses his or her loss, grieves or practices mourning. In this context, practicing cultural safety is of importance. Cultural safety means above all checking, are we on the same page? It focuses less on the patient and more on the caregiver. Cultural safety is distinct from cultural sensitivity and cultural competence. It is about reflexivity in examining the beliefs, values, and assumptions of healthcare professional held about the other, and how these might be influencing our perception and practice. Furthermore, it need reflection about healthcare professionals' own beliefs and assumptions, patterns of grief, coping strategies and possible barriers. Past losses and separations can have an impact on current losses, separations and attachments. People who have had a history of depressive illness also run a higher risk of developing a complicated reaction. While death and dying are for many people the ultimate trauma, people can experience similar emotional upset when dealing with many of life's challenges, especially if confronted with something for the first time. Clinical indicators of poor coping include perceived overreaction to bad news, psychological or behavioral restlessness, unusually high anxiety, excessive and persistent over-idealization of the future, persistent obsessive thoughts and preoccupation with the patient's well-being, inability to experience the various reactions typically found in people dealing with bad news, inability to articulate existing feelings and thoughts, chronic anger or combination of anger and depression. Healthcare professionals are often present at the times of loss, grief and bereavement. Typically, they do not necessarily have the knowledge, expertise or confidence to deal with bereaved individuals. Knowledge of theories of grief and bereavement can help healthcare professionals understand how people deal with the loss. Based on clinical indications of poor coping, referrals to specialists, such as psychologists, psychotherapists or healthcare chaplains could be of importance. Anyhow, grief is a normal process, which should not be medicalized. Furthermore, there is no normal in grief, as it is a unique experience. Every health professional working within palliative care needs to be aware of the psychological and spiritual needs of the patient and their family when adjusting to a life-limiting diagnosis. Current pressures in healthcare mean that physicians and other providers are pressured to act quickly, offering answers and quick fixes to complex multi-layered problems. Conversations with patients who are dying cannot be conducted in brief visits and often involve questions that have no answers. Trying to answer unanswerable questions may prevent the patient from further sharing and exploration of issues that are important to them. Being open about death allows the patient's focus to shift from the medical management to dying. Patients should be given resources and opportunities to search for meaning and purpose, if that is something they wish to explore. Having someone to talk to who is not sharing the burden of grief personally can be very helpful in allowing patients and carers to express their grief. Only by listening to the patient's full life story, told in their own words, can the full impact of their losses truly be understood. Armed with this insight, health professional can provide tailored meaningful treatment, which meets the needs of the patient and provides direction for the development of better care in the future. Attig describes the need to make meaning in the world following loss with emotional, psychological, behavioral, social, intellectual and spiritual transformation. A health system that focuses only on the physical does not afford patients the time, resources and attention to focus on this important aspect of their care. The quality of the relationship between the patient and health care workers has been shown previously to profoundly affect patient preferences and decisions surrounding care. If the relationship is one-dimensional, focusing only on medical and physical symptom management, this will also provide an unsatisfactory experience for the health professional, and psychological and spiritual adjustment to impending death will occur for neither party. There are things that families would like healthcare professionals to know. These are as follows. There is no right and wrong way to grieve a loss. Grief may involve extreme emotions and behaviors. There is no set timetable for grieving. Do talk, even if you don't know what to say. Knowing that you empathize is a good start. Do listen, it can be more important than what you say. Sometimes families just need to know that they are heard. Healthcare professionals need to ensure that they respect the individuality of the person and offer appropriate person-centered care and support. Connectedness is needed to understand and be aware of all the different factors that can influence the grieving process to be able to offer sensitive support to individuals who are suffering from loss, grief or are bereaved. And here are some final thoughts regarding loss, grief and bereavement. Health and well-being are of importance to everyone. Better palliative care happens when we listen to the concerns and wishes of patients and families, what matters most to them and not just what we can treat or we perceive to be important. Necessary supports for loss and grief are individual, and requires understanding and active engagement with patients and families.